Tonight, we ask you to tell us which country DFL's host Delia Dolar is in tonight, and which sponsor is she representing. The N says she's in Aruba, representing MAC Cosmetics. I will ask my co-host, guest, Angus, to pick the lucky winner from our bag of entries. Yeah?
I get to do the dirty.
And, well, the email is jazzyblue30@hotmail.com. Congratulations, Jazzy. We will give you the details how to collect your gift at the end of the show. Angus, during the break, you gave me some very startling statistics. I thought I had quite a few up my sleeve, but before we go to your statistics, though, because of its relevance, I just want to expound a little bit on what we just spoke just before the break. Who is to blame? Because perhaps if we know who to blame, perhaps it would be a good place to start in trying to find a solution to this problem. I will admit that it's no easy problem. I see patients from the US all the time, and I saw a 34-year-old patient a few years ago, and that's perhaps one of the things that registered in my mind the most was a 34-year-old guy who suffered a stroke, hypolipidemia, all the works. Suffered a stroke. But before he was depressed, he was on antidepressants, he was on antipsychotics, he was on sleep medication, a number of things. I mean, I'm talking about 2 sets of antidepressants, 2 sets of benzodiazepines. You have a long-acting alprazolam and you have a shorter-acting Valium, a concoction of meds. And I'm looking at this guy, I'm saying, where do I even begin? Because I'm here to write a prescription, because he comes and he says to me, Doc, you know what? I came from the US with this prescription. I need you to refill this prescription for me. I'm saying, how in the heck do I refill this?
But it's almost the first thing that you ask is, how is this guy still alive half the time?
Precisely. but we see a lot of them who are still alive. You know, the body is remarkable in the torture it can actually undergo, isn't it? You know, but who's to blame? I mean, is it the patient who comes in, ignorant sometimes, seeking help? Is it the physician who's trying to do his best to assist the patient? And having said that, though, it doesn't justify the patient who's looking for a quick buck, because you look in your waiting room and there are 30 patients, and there's one patient or 1 or 2 patients who walk in with a diagnosis and almost a treatment plan in hand and say, Doc, I have been on the X medication for the longest time. I had a back injury several years ago, and this is all I need. And it takes 5 minutes to cash in.
No, exactly.
You know,
exactly.
or less.
There are many pressures that come to bear on the physician in practice. Many of those pressures are actually outside of what we consider to be the medical field. Often those pressures come from the drug companies, as an example. That constantly pounding. They work their way insidiously into even the medical schools, and you know, a lot of the medications that are used often as a sidebar. In other words, you might be given there may be something which is an antipsychotic, but it may be that the physician has read somewhere that this particular antipsychotic works very well in small doses for helping people as a sleep aid. But what it doesn't say, unless you read a lot further along, is that these things are terribly addictive. And also, the side effects are such that is it actually worthwhile giving this patient this particular medication when here are the possible side effects of that.
I listen to you, and sometimes I wish you could be the fly on the wall in my office.
But that's why we consult sometimes.
You're still just a stone thrower for me, but I wish you could be the fly on the wall. And sometimes I'm forced to actually invite you in, and vice versa. Sometimes I'm forced to be invited in to consult on certain cases. But I mean, I'll tell you though, because you're also it's a complex problem because of the nature of the patient that you're dealing with.
Yes.
This is not the patient from a lot of times from a very low socioeconomic class who has very low intellect and that sort of thing. This is the patient who can be very manipulative because he comes across and he also has a commanding presence. He's usually an individual, he or she's usually an individual with means, and he comes to you and says to you, listen to me, I am, you know,
no, exactly.
I know, and seems in total control, because usually it's a patient who's already in control of several things, perhaps a company, whatever the case may be, you know. So he or she seems in total control and says, because you're not looking at the typical junkie who is the person who looks all worn down and just looking for a quick fix. You know, and this is what makes prescription drug abuse such a unique problem, such a difficult problem. But I kid you not, I dare say that it is perhaps as big, if not bigger, problem than illicit drug use or drug abuse.
Well, it probably is, and that brings an interesting little bit into the conversation, because how many doctors actually, to use a strange word, cotton on to the fact that some of these patients are dealing with are actually probably recreational, quote-unquote, cocaine users, as an example. And that's often true.
Of course.
You know, cocaine is one of these substances that's kind of dismissed, or it's not there, because crack cocaine is so prevalent and so evident when it's being used. But often people that you're talking about, these high-powered people, are cocaine users. How does that interact with the substance, with whatever prescription you might be giving them? They're drinking. Does that come into the question? Don't drink when you're taking this, but for someone who has a dependency on alcohol, is not going to stop drinking simply because they're taking a tablet, or often will not. So who monitors that other than the patient, who has come in simply to get the substance that he wants half of the time?
Do you really think, when last did you visit a pharmacy in Ireland? Do you really think that this little over-the-counter you know, interaction between the pharmacist, perhaps unless through a glass window, does that really allow, a lot of times there's a line, there's a queue, and there's 3 or 4 people right behind you, you know, I mean, is that enough interaction between a pharmacist and a patient? If I send you to a pharmacy with a prescription of a number of things, and a lot of times the patient asks me, how do I take this? And I say to them with some degree of confidence, when you get to the pharmacy, the pharmacist will explain to you how you need to take those. And when they come back, it's pretty evident that never really happened.
No, I mean, I have had to have prescription medications before, but I've never really been told, neither in England, nor in Canada, nor in the States, nor here, precisely what to be cautious of.
Precisely.
Because there is a caution to be added to all of these substances that are prescribed. And yet we're never really told that by the pharmacist.
For which I have to applaud, by the way. I have to applaud Tapia Hospital and Victoria Hospital. They both have consultation rooms.
Good. I've never been there.
Yeah, they both have consultation rooms. I saw it at Victoria Hospital and Tapia Hospital more recently, which I must applaud them for that, where a patient is taken in and at least half an hour is spent with that patient, going through the medication and explain to them a number of things, including the adverse effects and what to expect and that sort of thing.
Actually, I mean, granted, I'm probably not talking about psychotropic medications. At this point, so
sorry to cut you short, but we have to look at the phone. Good night. You're on the Dollar Factor. Good evening.
Good night to Dr. Pierre and your guest.
Thank you for calling.
Good evening.
Good evening.
The problem is a real problem, and all those involved, the pharmacist, the physician, the patients, they are all responsible for the health care, and I think they are all to be blamed. The problem is a real problem. Very real, more real than a lot of people think. I'll give you an incident that happened a few years ago, where I got a prescription from a patient. It was for pethidine. It's a young Caucasian lady. And of course, those narcotic prescriptions we keep in the pharmacy. It's not given back to the patient.
Right.
And when I went to enter it in the logbook, I noticed her name was there already. And I saw the number of tablets that she got.
Wow.
And I said, I went back to her and I said, but you just got some tablets and they're not finished yet. Why are you getting another prescription? And she gave me some story which I didn't really believe. So I decided to check the logbook and noticed that she was on that pethidine drug for a number of prescriptions. So I happened to call the doctor, and I noticed the same physician who was prescribing it to her. So I
Wow.
called him, and I said, look, I think we have a problem there.
Wow.
And he says, okay, don't fill it, just send her back to me.
Wow.
So she went back to him, and I didn't see her at all again until a whole year or so after. The person came back to the pharmacy and said to me, so you remember me? I said, no. She said, I came to thank you. She said, I
Wow.
just came from rehab because you're observant enough to notice that there was a problem with me. And she said, my friends had introduced it to me, and I was hooked and I couldn't get out of it. So what I'm saying that the problem is real, but the pharmacist has to be very observant.
But I take it that you're a pharmacist, caller.
Yes, I am. Yes,
I mean, creating a paper trail, for example, is necessary. I mean, we have to now become very computerized to the point where we begin to share information,
Very much
you know,
so.
and patients' information. There has to be some degree of confidentiality where among pharmacists you can share that information. If you log in, if I put my name, I'll appear. It should show how many times I filled.
many times, definitely.
Precisely. I mean, some issues are a very small island. It's
Yeah.
not like I'm going from state to state and filling prescriptions. You know, so it's pretty unfortunate that I mean, for example, in some cases you did this, but let's just assume for argument's sake you had not done that. You had just said to the patient, you know, I don't think I should refill this for you. Perhaps you should see a doctor again. Should just have gone across the street to the next pharmacy
The next pharmacist and get it.
precisely.
Definitely.
And congratulations for you
Yeah,
for
yeah.
responding in the way that you did.
But
you know.
you know, these things are real, and it's not only with narcotics, with a lot of other medication.
A number of other medications.
What is happening now, you find that patients are now forging physicians' signatures.
That's correct.
That's
I had
another
I had
area
I had an
pharmacists have
incident
been
myself
very,
recently.
Very,
Yeah.
very observant. Know the patient. Speak with the physicians when you're not sure. It's important.
It is.
Dialogue with all those concerned.
I thank you so much for calling. Thank you so much for calling. Have a good night.
Okay, good.
You know.
Thank you.
And this is a very, very important point that she brought up. I had a recent incident, Angus, where I was called to the pharmacy because a patient who I had filled a prescription for only 2 weeks wrote a 1 next to it, and it was for 12 weeks.
12,
But I will come back to this. I think we're due for a break right now, so we'll go straight to the break and we'll be back. You're with the Dual of Factor Life. Thank you for staying with us.